send the patient back. And this information has to be shared with the patients that they must take care of the gums in the pregnancy, not only because it bleeds, but also it can complicate their pregnancy because, like I showed in the earlier slides, the role of periodontal inflammation is there on the health of the baby. Uh, Similar case now, this patient was getting multiple scannings done and did not respond to the clinic. So we often see these patients in our practice where the patients keep on coming back for the scannings and they say, doc, I mean, the bleeding reduced for 10 days or 14 days or 20 days, but now it's come back. And they are not actually the patients for flap surgeries because the pocket depths are just 4 to 5 millimeters and you're not comfortable doing flap, especially if there's an anterior area like this which can play with the aesthetics. It can be a recession or a sensitive case. So we don't know what to do in these cases. So one needs to understand, if we are doing scaling and root planings regularly and still the bleeding is coming back, then it's a case of chronic inflammation, and we need to address that inflammation with something more than scaling and root planing, but less than the flap. So we check the pocket depth, and we follow this protocol of dual laser wave therapy, or you can just use an erbium laser, or probably just 940 nanometer, just to at least control some inflammation. So this concept of dual laser is supported by the articles by Dr. Arlen Oder and Dr. Goodnet, which talk about that when you use the diode and BioZG in combination, you take the benefits of both the properties, and the results are very promising with that. So you use a diode laser, you've got the settings on the screen for outer pocket, inner pocket devitalization. And then I take my erbium laser and do the inner pocket devitalization and clean the root surface with the erbium laser. And this is how the patient looks immediately post-op. And this is how the patient looks after 7 days. Now, I was not very happy because I could see some black triangles, and this was an area of concern. But since I told you that laser has a bystander effect of photobiomodulation, so I would just let it heal and ask the patient to keep it clean with the air flosser or maybe a brush, interdental brush. And this is how the patient responds, because now the papillas are filled, there is no more inflammation. I can see the papilla is no more angry looking, it's not red, inflamed, it's not bleeding. The pubic depths are very stable, they're reduced now. And you can see the progress of the patient from pre-op to post-op. And now it's been, I know him for at least 7 years and he's still like this. So yeah, he's been maintaining well. Maintenance is another added factor that needs to be taken care of when we're seeing the patients. Now, talking about the review of literature, so there's a lot of debates going on the role of lasers in periodontal therapy. So if you see the article by Dr. Charles Cobb in 2006, it says that Nd:YAG and YAG wavelengths or beam lasers could be equivalent to scaling root planing, but we need more evidence to suggest that they're superior to traditional modalities. And because of this article and the other position paper in 2010, there's a lot of resistance amongst the periodontists in using lasers. But if you see the 2018 American Academy of Periodontology best evidence consensus, it says that the lasers can, they suggest that it can elicit similar or slightly better outcomes than the laser, than your conventional treatments. But we need more evidence. Why do we need more evidence? Because we have so many laser companies, so many laser units, different energies. There are so many parameters. So we are not, though we have, if you search laser dentistry or erbium lasers, you have over 500 articles, and they are all in good publications. For example, JOPs and P2000 review articles would suggest that you have a good effect, or it would be IJPRD. So all good journals have these amazing studies, but because every study uses a different parameter or the settings or the powers or frequencies, we are not able to club them together to have a meta-analysis. And that's why Dr. Daniel Stevens, who's the president of current AAP, says that the latest findings are not meant to insinuate that laser usage is more or less beneficial, but the Academy says that in the absence of critical mass of evidence, all practitioners must rely on their judgment and expert trainings and decisions. So they are not denying the fact that the lasers are not beneficial, because honestly, if you speak to all of them one to one, all of them are using it in the practice. And I just probably we just have to wait for another few years to have meta-analysis. And Dr. Stephen Daniel at the BEC does emphasizes that laser safety programs and adequate trainings are mandatory if you need the results, because we know they are established studies, we have the results, but you cannot be delivering any energy and just buying it as a machine and not learning the science behind it to use it. And because the BCA had requested to have a specific multi-controlled trial randomized study, Dr. Donald Clem and Dr. McGuire and Todd Shire, they together came in to do a study where they compared the technique by quaternary, which is the mist technique, with the YCG laser, and they compared both the treatments. And then they found that your laser treatment without anesthetic, the peri-repair protocol, is similar in clinical outcomes to your flap surgery, which is by the Dr. Cottinelli, but is also superior in terms of patient-reported outcomes. The patient were more comfortable. They were not traumatic because, of course, when you tell the patient that you have to go into the surgery, 90% of the patients decline the treatment because they do not want to imagine that surgical intervention. But if you promise the patients the results with a non-surgical means, which is permanent and definitive, there are hardly any patient who would say no to you. So now we have first of its kinds multi-center randomized controlled trial, and we hope that we have more similar studies in future so that we have the consensus finally in the AAP as well. Now, this is just the last case. This is not the part of my webinar, but just to show you what's going on in the advanced lasers. When we talk about the role of lasers in periodontal disease, we also talk about the role of lasers or the erbium lasers in root recession, which is a part of periodontal disease. So this patient was referred to me because the patient had a frequent sinus with respect to the lateral incisor on the left side, 2-2, and was concerned with the growing recessions on 2-3 and 2-4. So we did the CT scan for the patient, and we realized the patient 2-2 was immobile and did not have any problem, and she was comfortable. So we just went ahead and did the episectomy for her with the help of erbium laser, and decided to do the root coverage for the adjacent teeth. So we did a laser flap with the erbium to raise the flap. We did the axis, clean everything with the bone, with the erbium laser on the bone, created a window for the root access, used the erbium laser again to do the episectomy with the laser, and then clean the socket and make sure it's all clean. And then the advantage is that number one, it cleans the granulation tissue, and number two, it decorticates the bone, so you have more growth factor, so I don't have to graft it now. And then I went ahead and used this laser to de-epithelize the connective tissue graft, because there's a free gingival graft and you have to de-epithelize, so you can take out the connective tissue part and use it for your root coverage. So this technique has been studied and documented by Dr. David Kim and Jerry Lynn, and they have given the settings where you can use, and it's safe. It has zero side effect on the healing of the graft or on the life of the graft, and this is how you take out a graft. And I suture the graft, but you're also suturing to stabilize the grafts, and close the flap. And this is how the patient heals at 1 month after suture removal. And this is your final healing. So this is where we are heading now, because I did not use any sort of blades in the surgery. We used the erbium laser to open the flap, clean the bone, clean the socket, cut the root, take out the graft, and suture. So yes, there are situations where I want to use the blade because I cannot have an access with the erbium laser. But the healing with the mechanical blade and the healing with the erbium laser is very different, and it's very promising when I'm using an erbium laser, especially when I'm using it in medically compromised patients or refractory treatments. So coming on to the conclusion and advantages of an erbium laser. Number one, we all know it's bactericidal and leads to the detoxification. It can remove the endotoxins which are present on the roots, which cannot be taken out with the ultrasonic scalers and curettes. Number two, it leads to 3D healing. Why 3D healing? It takes care of soft tissue, it takes care of your hard tissue, and it takes care of your post-modulatory agents, which are responsible for the destruction of the tissues. Then it removes the smear layers and promote new attachments, because when you use erbium lasers on the root surface, the new fibroblasts that comes out, they are actually spindle shaped, and these spindle shaped fibroblasts they have better affinity to touch on to attach to the root surface. Then, as I said, super safe and super predictable in patients who are medically compromised, patients who are diabetic, patients who are anticoagulants, patients who are recovering from COVID, patients who are pregnant. You can easily, or patients who are not aggressive periodontitis, where you can't do the flap surgeries again and again because the patient's genetics are compromised. So of course you can go ahead, because you can always repeat the laser treatment even if it comes back, because aggressive periodontitis, you do have patients where the problem comes back. So I don't see any problem in doing it with the laser. And definitely it's very site specific. If you do a flap, you have to raise one tooth mesial, one tooth distal, and raise all 3 to 4 teeth to do one single tooth. But instead of if you are using a laser, you just have to take the tip where you have the pocket, clean that area, and that's it. So it's very site specific. And areas which are anatomically different and difficult to access, like mandibular molars or your palatal mucosas, you can just go ahead and clean the areas, and zero complications during and after the surgery. I have never had any patient in last 9 years who had come back to me and told me that there were some complications after my laser work. Now, there's an additional benefit of these erbium lasers, is that minimal aerosols production. Now, this benefit is very relevant in today's time, where we want minimal aerosols production. So when we did a study and compared the drill and bottles, we saw that there's a 70% reduction in the aerosols which are produced by YSCG. So this is a landmark study by Dr. Joseph and Dr. Marina Polinsky, and they compared both the modalities, the ultrasonics and the drills and the lasers, and they saw that there was 70% less reduction when you're using the YSCG. So that serves the protocol for the aerosols as well. Again, that's my course, 7th, 8th, 9th Associate Fellowship in Laser Dentistry, New Delhi. If anybody is interested, please get in touch. We would be happy to have you with us. Thank you very much for your attention and for your time. I hope you all have a good weekend. You stay safe, and the presentation benefited you in some way. Thank you so much. Okay. Amanda, I can't hear you. Are you there?
Yes, ma'am, I'm you.
Okay, can we start the questions?
Yes, yes.
Okay, fine. So the question answers, Dr. Simrat. If we are cleaning and disinfecting an extraction socket with a diode laser, will it affect the osteoblasts? Can we go ahead with an immediate implant placement? Doctor, thank you for the question. That's an amazing question. Yes, you can use the extraction socket with a diode laser. I would not suggest you to touch the diode laser on the walls of the bone. You have to use the mechanism of photobiomodulation or disinfection. That means if you're using a regular handpiece with a spot area 1 centimeter square, you would use somewhere around 0.5 watts continuous mode for 30 to 40 seconds. And it wouldn't affect osteoblasts. Definitely not, because this is if you're delivering around 4 to 6 joules per centimeter square, so that is leading to proliferations of the blastic cells. So it would help your osseointegration to be better. In fact, when I place implants, I always do my photobiomodulation, one round of photobiomodulation buccally and palatally, because we have several studies to tell us that doing this increases your osseointegration. So you can go ahead and place an immediate implants. I hope that helps you. Okay. Do we have? Okay. Let's chat. Let's see question answers. Okay. In case of another question, in case of peri-implant disease, can a diode laser come in contact with the exposed implant threads? Doc, no, the diode laser cannot come in contact for your implants threads, because the diode is a thermal, like I said, it's a photothermal diode laser. So it has thermal effects. And if it touches the titanium beyond an energy density, that can affect your rebonding or the re-osseointegration. So I wouldn't suggest you touching the diode. As of now, we don't have any studies where you can touch the diodes on the threads, but you can at a distance of zero point 0.5 to 1 millimeter at a distance, you can do irradiation with the diode laser so that at least your bactericidal effect is there. But mechanically, you would be using your Teflon brushes, titanium brushes, and some curettes to mechanically clean. So it would be a adjunct, a diode laser in a non-contact mode, plus your mechanical therapy, and maybe if you believe in your some fibers, tetracycline fibers, or some citric acid cleaning, then you can go ahead and use those with the titanium brushes. Won't YSGG, there's another question, won't YSGG evaporate and desiccate the dentine, causing sensitivity? No, doc. So that's what we say when we talk about the laser. We are talking about a lot of specific energy densities. I said that your pulses per second is very important. So if you overuse it or underuse it, you don't get any results. So if you're using a YSGG laser to remove the bacteria, so the dentine has, for instance, 30-40% water, but your bacteria or the diseased dentine would have 70% of the water. So automatically that would evaporate first, and the healthy dentine would be remaining. And the rest is visually and with your curates, you have to check that if you still have soft dentine remaining. So no, it wouldn't evaporate the dentine or healthy dentine. It would just evaporate the bacteria or the caries, because the caries is nothing but 70-80% water. So automatically it will select that 80% water with the caries and evaporate that and not your dentine. But if you overdo it and you do not stop, then of course it's going to evaporate the dentine as well. So the next question is, the patient who came in for a full mouth implant case where you did a periotherapy, can we achieve the same results with the diode laser? Doc, yes, we cannot achieve. I wouldn't say that we can achieve same results with the diode laser, because I cannot have a bone fill with a diode laser. But I would say that we can achieve 60% with the diode laser. At least some inflammation would be definitely subsided and it would be taken care of. So no, not the same results, because you cannot use the diode laser on the root surface cementum. You can't enhance the fibroblast attachment. You can't remove the smear layer. You can't attempt a bone fill with the diode laser. So not the same results, but at least your pocket depth would reduce by 2 millimeter, which is not too much. You might have to do multiple sessions of diode laser after every 1 week or 10 days. You might have to do 2 to 3 sessions of diode laser, but yeah, you can stabilize the periodontium, but you would need to do some definitive treatment like open flap plus diode and something. But only diode wouldn't suffice the treatment. During laser therapy in perio case, patient was given medication. Doc, I'm not sure which perio case are you talking about. But if you're asking about the post-op medications or pre-medication, then I do not give any pre-medication unless the patient is super anxious. Then maybe one Alprex, 0.5 mg. And if you're talking about the post-operative medications, then we usually give painkillers as when required. It's need-based, and I don't give anything else. Yes, if the patient is medically compromised, for example, the patient is aggressive periodontitis or has a refractory periodontitis, or has metabolic syndrome, or has some sort of arthritis, then I would put the patient on Augmentin and metronidazole for a 5 days course. And that is because the patient is medically compromised, and it helps building up my collagen fibers and taking care of my microbiological agents. So otherwise, in a regular patient, I would never do it. So I did not give the medication to my perio patient who was the cancer survivor, but the second patient was diabetic. Yes, I did. There is a question, may I know if the laser course conducted by you has hands-on on patients too? Doc, yes, we have the hands-on too. That's the best part of the course, because unless you do it on the patients, you don't get to know what it is. I am not sure if we would be doing the patient hands-on in this batch in August because of the concerns of the pandemic. But even if we don't do it, you would be given an permission to come in any of the future batches and finish your hands-on. And if the situation allows closer to the month, we may have a patient's hands-on. At the moment, we have the patient hands-on. So let's see closer to the date, whatever the situation allows us. There's a question. Would you try to save a tooth that is grade 3 mobility with laser? Doc, I would never try to do it because when you try to save a tooth which has grade 3 mobility, you are actually jeopardizing the bone because any tooth that has grade 3 mobility hits with the other tooth structures and leads to pathological migration and usually has inflamed periodontium, the periodontal ligament. So if I try to save on to the tooth which is grade 3, I am actually putting my future bone or implant in jeopardy. So grade 3, I wouldn't want to save. I would want to pull it out. What is the annual maintenance with Epic X model and Waterlace? Doc, I am not sure about the annual maintenance of the machines. I can talk about what is the expense that I bear. Um, for Epic, I don't remember because my staff does it for me. I think one tip is close to 800 rupees, and you can use that tip autoclave. That's the beauty of this Epic laser because it doesn't have a coil, it doesn't have that attachment, and you can just use it and clean it with the ethyl alcohol, autoclave it, and reuse it. And if you don't overuse your tip and don't put pressure, don't use excessive energies, then at least one tip would serve you for at least 15 to 20 patients, which is a lot. So 800, you have to divide it by 20. That's the cost you have for the Epic. So Epic for me is just one-time investment. And annual maintenance, Waterlace is again just one-time investment because you have distilled water. There is no maintenance for the Waterlace. So it's just one-time investment. Do we have the same photobiomodulation effect with the YSGG when compared to the diode laser? No, doctor, we don't have the photobiomodulation effect. Why? Because for photobiomodulation to happen, you need depth of penetration. You need some laser light that goes to the deeper structures of the tissues because your diodes have deeper penetration and low absorption in water. That is why you can use those wavelengths like 500, 600, 980, 1064. All these can be used for your photobiomodulation. But a YSGG does not have a depth of penetration, so you cannot use it for your photobiomodulation. I hope that helps you. Another question, could you please shed light on the incidence of post-treatment sensitivity and management? Doc, in the last span of 9 years, I've never had any patient who had sensitivity post my work. Also, it has to do with your instrumentation. If you over instrument your root planings, if you overdo it, if you remove over cementum, you of course definitely land up into sensitivity. So your sensitivity is not to do with your periodontal disease, it has to do with your management of instrumentation. So you need to know where to stop, be it laser, be it mechanical instrumentation. And post-op management, I would just, for me, the most important thing is the patient has to be in the follow-ups with me. So first, I like to see the patient post 48 hours because he's hesitant to brush. So I'll just do one round of cleaning. Then I see the patient post 1 month. So if the patient is a chronic case with a lot of deeper cropping depths, then I would see the patient every month for first 3 to 4 months. Then I'll increase the gap to 3 months and then 6 months. And otherwise, post-op, I would just ask the patient to come and see me in 48 hours and then 1 month, and that's it. And just maintain. So maintenance, yes, but as such, there is no management. The patient has to be on a soft diet for maybe 24 hours and gentle brushing around the areas for 24 hours. That's it. But they can socialize, they can talk, they can eat, which is usually not the case in the flap surgeries. Can you please explain the settings in a diode laser for treating for ulcers? Doc, if we are talking about aphthous ulcers, then we are talking about relieving the pain. And if you're using a biolace, because you have different wavelengths and different settings, if you are using a biolace 940 nanometer, then the setting for the ulcer would be 0.5 watt continuous mode for 20 to 30 seconds. This would help you healing. Use a regular handpiece, and you can either use a stationary movement or like a scanning technique and keep it at a distance of 0.5 to 1 mm. The patient should not feel the burning. They are allowed to feel a little bit of warmth, and that's just the right distance. And you can do one round and you wait for the tissues to cool down. And then you can do one more round and ask the patient to touch the ulcer with the tip of the tongue. And they would say that I don't feel anything. That's when you know that the treatment is over. Is there any way to achieve anything similar to the perio repair protocol with the diode laser? No, Dr. Tanmay, no, we cannot. There is no technique to achieve something similar, but you would achieve something very close. See, you cannot grow bone with a diode laser because it's a soft tissue laser. You cannot touch a diode on the bone or a cementum or a hard tissue. But even if you use a diode laser and you avoid flaps, you would get definitely minimum 70% of the results. And again, I would say it's just not you are doing a diode laser. You have to do the systemic planning. You have to do your phase one therapies. You have to diagnose it, right? You have to see if it's a trauma from occlusion. What is causing the problem? So if you address all the aspects and plus you use a diode laser, 70-80% results, 100% you're going to get, but you wouldn't get your bone fill. The next question is, in case of depigmentation, which lasers is there any chance of pigmentation again? Dr. Chauhan, thank you for your question. You can use either one of them, and pigmentation is usually genetic. So it could be a reason of your some liver problem or some diabetes or smoking, or you may have some tattoos. So you have to find the etiology, and if the etiology is systemic, then in that situation you have to tell the patient that it is something which is inside the body and we cannot change the genetics. So usually I see that the pigmentation comes back in 1 year to 1.5 years. But what I've seen significant change is that when I do the second round of depigmentation with the laser after 2 or 3 years, we don't see same kind of pigmentation. It's reduced already by 40 to 50%, which means if I do a pigmentation every year for 3 years, by fourth year, the patient would not have any pigmentation, but you have to do multiple cycles. But definitely it's going to come back because it's your genetic makeup, and this information has to be shared with the patient that it is something like your facials or your cosmetic surgeries that you have to, it's like Botox fillers. You always have to keep on doing it. It's not a permanent procedure. But most of the patients don't mind getting it done because number one, it needs no local anesthetic. Number two, super nice results. And number three, it takes at least just like 3 to 4 minutes. So it's not too much for the patient to come back and get the procedure done again. After frenectomy or gingivectomy by a diode laser, is it necessary for a periodontal dressing in the surgical area? Thank you, Dr. Dharani, for this amazing question. I am happy that you brought this up. So there was a time when we all periodontists used to do everything and put a dressing, and that was actually to hide our work because we didn't want to even see ourselves at what's going to happen. We used to just pray that, okay, the graft is there and let's put the dressing so that it doesn't move. But I would never do that now because all the cases that I go back and see where I had put the dressing, there's so much of food lodgement that it delays my healing. So if you see the recent articles in the researches, they don't say that you have to put the dressings, especially if you're doing a frenectomy or a gingivectomy, definitely not dressings. The only time I remember putting a periodontal dressing is when I'm harvesting my grafts from the palate is where I put my dressings and the co-packs. Otherwise, if you feel that it's a frenum, it's an open area and the food can get lodged, no. Do you give a dressing after extraction? No, we don't. We pull out a tooth and there's a big space, even if you've pulled out 2, 3 molars and premolars together, and it just heals. There's no food lodgement inside. So it's the same. Frenectomy is just half of what we do during the extraction. So if we don't put any dressing during the extractions, then definitely no dressings after the frenectomy. So it's going to just hamper your healing. And also when you're doing a frenectomy and a gingivectomy, the laser heals by secondary, it's not secondary intention, it's a tertiary intention, where you have a fibrin clot. So you see some white areas which is filling up that space, and that white healing fibrin is very important because that's a protein coagulation happening, which will bring in the epitheliums from the sides to make a bed. So if you put a dressing, that entire process is is scarred. So no dressings after any of the laser procedures. Another question. Can you elaborate your technique for open flap surgery with a diode laser? Dr. Hina, I would not do an open flap surgery with a diode laser. You cannot, I repeat, diode laser is only for a soft tissue. You cannot do an open flap surgery with a diode laser. Yes, you can use a blade to open your flaps. You can use your curettes and scalers to clean the root surface. Then you can use a diode laser to deepithelize the inner wall of the flap. That you can do. 1.5 watt continuous mode. Just take out all the granulation tissue and take a wet gauze and scrub it off, because there should be no charring left, and then you suture it back. That you can do, but you cannot raise the flap using a diode laser tip. So the question is, may I ask how we can remove old veneers by biolace, waterlace? Does a laser removing or damaging the hard tissue, or it can be dissolved the veneer cements only? Doc, that's again a very good question. So we often use our waterlaces to remove the veneers. The beauty of it is it breaks, like you said, it breaks the cements and the water in the cements, so the veneer just separates from the tooth. And no, it doesn't affect your tooth structure at all. In fact, you can just retrieve the entire veneer without breaking it into two or few pieces. So yes, you can remove your veneers, and usually you use the settings of 5 to 6 watts perpendicular to your veneer, and you move it at the line angles for 2 to 3 minutes, and then you take your instrument and it just comes out. Next question: do we have to go in the contact mode, non-contact mode, and whether the tip has to be activated for treating the aphthous ulcers? Doc, for aphthous ulcers, you always have to be non-contact mode. You will only use the contact mode if you are ablating, if you're cutting something, if you want to touch the surface. If your aim is not removing or cutting or regeneration, then no, you are not going to be using the laser diode in the contact mode. So your question answer is that you will be using in non-contact mode, and definitely non-initiated tip. You initiate your tip only when you want your laser beams to be, segregating at the tip, so that it's faster cutting. You create a tip effect, but we don't want it. Also, we want to use the nerve cauterization actually, and we want to make a coating on the ulcer so it doesn't hurt the patient. So it's non-initiated tip, non-activated form, non-contact mode, and at a distance of 0 to 0.5 millimeter, and just move it, keep on moving very slowly for 60 to 90 seconds if you're using 0.5 watt continuous mode. Next question: if diode laser is irradiated to the roots in open flap debridement for an infrabony defect, will it increase the bone fill to some extent? Doc, it's nothing to do with your diode laser. Diode laser would definitely, if you just irradiate in a non-contact mode, like I said, it leads to bactericidal effect. It definitely will decrease your bacterial load, but your physical mechanical debridement with your curates has to be meticulous. Like, remove every speck of granulation tissue, and then you have a bone fill. So if you go back to your studies where you compare your open flap surgeries versus bone grafting and GTR, you see that if you have an open flap and you have done scaling, root planing, and clean the intrabony defect with your curates is one, and the second is you bone graft and you do the GTR, you may have similar results. So which means that if your defect is clean, it will automatically fill, diode or no diode. So yes, so if your mechanical cleaning with the curates of that intrabony defect and the root planing is meticulous, 100% you're going to have some bone fill, provided it's an angular defect, number one. And the laser is going to help you because it's going to help the regeneration of your fibroblast. So this is what I do. A lot of times I do the open flap and I irradiate the area with the diode laser. Dr. Pramod, can you take us through your course content for 3 days? Doc, it's a 3-day content. Day 1, we do the soft tissue lasers, A to Z of soft tissue in all the subjects. Then day 2, we do all tissue lasers, that what you just saw, erbium lasers. Then usually day 3, we do the hands-on the goat jaws. Hands-on include your cavity preparations on the teeth, your making the block grafts from your bone, and of course your gingivectomy, splenectomy, depigmentation, everything, all the exercises, your whitening, your photobiomodulations. So also your day 3 is actually your patient work. Like I said, I'm not sure that I would be happy looking at the safety of my participants and my patients, but if the time allows, definitely if closer to the August month we would feel that it's safe, we would be doing the patient work. Else you would be given an option to come back and just do patient work whenever you want, at my place or with the center or during the course. And also the 3-day course consists of an exam which you have to clear. Only if you clear the exam is when you get the certification. So yeah, that's the course content. The question, can you share settings for treating patients with sensitivity with diode laser? Doc, the settings for sensitivity is going to be zero point 0.5 watts, continuous mode, 20 to 30 seconds. So it's ideal to use fluoride toothpaste or stannous fluoride or some sort of anti-sensitizing gel or toothpaste. So use that first and then you irradiate and you ask the patient to blow in air. And if the patient says that I feel better, but it's still there, that one more round after 20 seconds and that's it. And sometimes you have to ask the patient to come back in 48 hours to do one more sitting. But most of my patients have recovered in one sitting. Also, you have to address the etiology of the sensitivity. Is it abfractions? It is TFO, then you need a night guard or an NTI appliance. So, laser plus addressing the etiology is going to help your patients. Next question, can you please throw some light on using the diode laser for biostimulation? So that's a very vast topic. That's a full day lecture, probably a 3-day lecture for me to use diode lasers in biostimulation because you use it in so many aspects and areas and specialities for endodontics and for perio. But yeah, the diode lasers, because like I said, they have depth of penetration and they can reach to the level, they can treat the TMJ pain. If you have a lot of pain, you can use your contour handpiece and just move it along your masseter muscles, temporalis, and your sternocleidomastoid and trapezius muscles. So it just releases those tensions, and you have to do that settings twice a week for 3 weeks if you are addressing TMJ. You can use your, if you take out the grafts from the palate, just a round of biostimulation so the area heals very faster. If you are using photobiomodulation for your sensitivity or after surgeries, I discussed that. If you're using it post surgeries, post implants, it increases osseointegration. If you're using your diode lasers for your orthodontics movement, so every time the patient comes in for brackets, you stimulate it with your laser, and it's seen that any your treatment time is actually reduced by 3 months if you're using this correct setting. So I cannot go one by one with all the settings because each category needs different settings. But yes, there is a vast role of diode. That's the main when you say there lasers are magic, that is the magic in dentistry. Ma'am, the question is that treatment in non-contact mode or contact mode for sensitivity, non-contact mode. So whenever you are talking about pain, healing, regeneration, all these things, they're always in non-contact mode. Regular handpiece without the tips, non-initiated. Question, will it require a special fiber tip for the use of diode laser irradiation in open flap debridement, or all the procedure require the same fiber tip? Doc, that's a very good question actually. So no, you don't need one tip, you need different tips. So you have 200, 300 and 400. These three diameters are available. 200 microns is super thin, so you can use it in endodontic canals. If you try to use that super thin tip for your debridement, you're going to break the tips. So for perio pockets, you have 300 microns. For your work, what you want to do in the inner flap debridement, you would be using a 400 micron tip, which is a white tip for 940 nanometer. Next question. What all things to be kept in mind if we are initially switching to lasers, as in new to lasers? Doc, that's another very relevant question. So when you are new to switching the lasers, what needs to be kept in mind is number one, like I told you, the training. Because unfortunately, all of us, this is how I also started. We all buy the machines and try to use it like an Apple iPhone. We Google it and see something on Facebook, call some seniors and try using it. And for so many years, unfortunately, a laser has been used like a glorified knife. We rarely you know the properties of a laser. So I would suggest that you get in touch with the articles. Just type the word laser dentistry or whatever you want to learn and learn about it, read about it, and see if that interests you. Get yourself trained, and then you see what kind of patients you're looking at. Are you in a hospital setup? Then you would probably need some kind of multi wavelengths or some photobiomodulation wavelengths. If you're in a practice which has more of tooth cavities and children, then I would suggest erbium lasers. If it's a normal, you're asking general, then a diode laser would suffice. So laser is something which is like a mainstay, and it's here to stay, and it's not a machine. It's very unfortunate that people compare it with blades and people compare it with conventional therapies. It is as imperative and important as your ultrasonic scale, especially your post-COVID eras where patients are looking for short appointments and disinfectants. And the moment you tell the patient that, okay, I'm going to be doing this procedure, it will take me 1 minute without anesthetic and zero bacteria, this patient agrees to it. So now, post COVID is going to be an era of disinfection, and anything that helps that is going to be in the market. So, yes, if you are thinking about switching to lasers, it's definitely a good idea. And if just place yourself in the patient's foot, that if you had to get a procedure done, you would never do a blade for yourself. You would look for somebody out who's good in lasers for your gingivectomy or frenectomy, and the same needs to be offered to the patient. Thank you. I think we have answered all. Do we have some more questions, Amanda?
No, ma'am, that's it. There are no questions in the chat as well.
Okay, great. So,
thank you all for attending today's webinar, and I would like to thank Dr. Apurva for her fabulous presentation. Thank you, ma'am.
you're welcome. Thank you all for your kind attention and being part of the presentation with us. I hope you're all safe and follow all the protocols because the pandemic is still here. Take care. Thank you.